Good morning, ladies and gentlemen. Welcome to Grand Rounds. I'm going to do a brief introduction while we let people join the call. We've got lots of people jumping on right now, so I'll go a little bit slow here to give people time. But my name is Jed Thompson. I'm the Associate Director of Communication for the department, and I'd like to welcome you here. This is Grand Rounds presented by the Department of Psychiatry and Behavioral Sciences, and today's lecture is a Ripley Memorial Lecture. So welcome. A couple bits of housekeeping to go over before we start the presentation. First, we will have an evaluation form at the end. So if you have any feedback after today's presentation, once the webinar closes, you'll see a link. It will pop up, and we'd love to hear your feedback. We would also love to have you join us for our next Grand Rounds presentation, which will once again be at the same time, noon, West Coast time, next Friday. And next week, we'll be learning about collaborative care. So please plan to join us for that. And also, we are going to hopefully have a little bit of time at the end for questions and answers. So at any point during the presentation today, if you have any questions, go ahead and use the Q&A feature in the webinar here. Type those in, and I'll queue those up, and we'll go over those at the end. The chat feature will be working as well. So either way, enter those questions, and I will be able to see them. So once again, thank you all for being here today. And now I am going to toss it over to the chair of our department, Dr. Jürgen Unitzer, who's going to announce or introduce today's presenter. Jürgen?
Yep. Thank you, Jed. Good afternoon and welcome to Psychiatry Grand Rounds. As Jed said, today I have the great pleasure of introducing our speaker, Dr. Kimberly Yonkers. And so I'll tell you a little bit about Dr. Yonkers. Dr. Yonkers is the Katz Family Chair of Psychiatry at UMass Medical School and UMass Memorial Medical Center. She's a psychiatrist. She's a fabulous physician scientist. She's had a tremendous impact on our field, in particularly in the area of women's mental health. Her research has been funded for well over 20 years, I think now, by the National Institute of Health with really great projects focusing on ways that we can use to identify, to engage, and to treat mood disorders and substance use disorders in women during the peripartum period. Dr. Yonkers also has tremendous leadership experience. She has chaired a number of study sections at the NIH. She was a member of the task force for DSM-5. She served as president of a bunch of professional societies, chaired the Women's Committee for the American College of Neuropsychopharmacology, and has participated in a whole host of planning efforts, strategic thinking efforts for our field. She's really a tremendous leader in our field. She's a great colleague. She's a wonderful mentor and inspiration to many, including our own faculty and staff and trainees who are passionate about helping individuals with substance use disorders during the peripartum period. And with that, please join me in giving a warm welcome to Dr. Kimberly Yonkers.
Thank you so much, Jürgen. I'm sort of looking around the room for this person that you were just talking about, but that's a very generous introduction. And it's a pleasure to be there virtually. I'm over in Massachusetts, so it's quite a distance, but I wish that I could be there in person. I guess this is a presentation that acknowledges Dr. Ripley, who has served as the first chair of the department, which is very impressive. I didn't know about Dr. Ripley, but he apparently passed away in 1982, but was a leader in psychiatry as well as your department. So it's a privilege to be part of that series. So as you heard, we're going to be discussing, or I'll be discussing, substance use in pregnant individuals today, and really kind of focusing on a lot of the work that I've done with a touch of the literature, and especially as it pertains to the epidemiology. Here's a list of my disclosures. I am an author for UpToDate. a recipient of research grants from NIAAA, PCORI, NIMH, and the editor of the Journal of Nervous Mental Disease, which I might plug a bit. It is a journal that is about 150 years old. It really focuses on that intersection between psychiatry and psychology. For those of you that know the journal, you will see many changes coming forward from the new leadership of the journal, but we're excited and thrilled to be part of that. We're leading that. So this is just a list of some of the things I'll be touching on today. I'm going to share with you some of the more recent epidemiology, screening, and course of treatment as it pertains to perinatal individuals with substance use disorders. So the National Survey on Drug Use and Health has really been an invaluable source of information for us. And these data are taken from the National Survey on Drug Use and Health, and it provides an estimate of past year substance use disorders in females. So you see that these are conditions that are not uncommon. About 21 million females, or about 15% of the population, have a substance use disorder. So that's not substance use, that is a disorder. And when we break that down, the winners are really alcohol use disorder. And as a codicil, I'll just mention there's been a lot of emphasis on illicit substances and opioids. And yes, the death rate and what's happening in terms of the opioid crisis is terrible. But alcohol use disorder really exerts a tremendous effect on our population and many populations. And you can see that here. It's about 8.5% of the female population. And you see here's drug use disorders, marijuana. Now, I should mention there's always a lag in the data that we receive from the National Survey on Drug Use and Health. So even the most up-to-date data will be about 2 years old. And I hazard to say that this number has ticked up a bit. Pain reliever use disorder, stimulants, methamphetamines, cocaine, and heroin. So, the story, as I just mentioned with opioids, is the prevalence is far less, but the impact is greater. Alcohol use disorder has a higher prevalence with a very substantial impact. And here, what I'm showing you are age categories for it. When I was a resident, medical student, junior attending, I was very interested in sex differences and conditions and gender differences, sex differences in metabolism of medications and the effects of medications. And one of the things that led me to working with perinatal populations is you kind of go where the money is. That's where the big differences are. And as you look at this particular chart, if you focus on this 18 to 25, there is this intersection between reproductive age individuals and substance use disorder, because many of the people we know weren't pregnant between 18 and 25, but when you look across the population, that's the most common interval for pregnancy. And so you see this substance use disorder in general, alcohol use, and drug use disorder. And in fact, female young adults, so in current parlance, I think we would call them emerging adults, were the most likely to have a past year substance use disorder, alcohol use disorder, or drug use disorder. And one of the problems with that is we tend to see that people who have these conditions don't receive the treatment that they need. And part of that is their perception of treatment is not high. So of the individuals who have a need for substance use treatment, well over 90% do not receive it. And one of the major reasons is they don't think they needed the treatment. So what this means is, as we think about reaching these populations and trying to make an impact, we have to take that into consideration and how we can motivate people to receive the treatment that they maybe don't feel they need. Co-occurrence of substance use disorders and other mental health disorders are very, very common in this population, just as in any population. So 8.5% of female adults age 18 and older had a co-occurring substance use disorder and another mental disorder, or serious or acute mental disorder. So what's the take-home message from that? We're looking at complexity. So these are not simple fixes. We have two conditions that we have to pay attention to, and we have to help people manage. Over half of the female population, 18 to 25, also in that group, there was complexity. The emerging youth group had an SUD and a mental disorder. Now, when we turn to pregnancy, and these are still data from the National Survey on Drug Use and Health, it does have that lag that I mentioned. But you see that one of the take-home messages from this graph, it shows that the rates of substance use are actually lower in pregnant individuals than non-pregnant individuals. And people in my department are probably have probably heard me say this before, and it came up in a journal club we just had the other day, that one of the best treatments for substance use conditions is pregnancy, because you see this effect. Unfortunately, it's not enduring. It doesn't last after pregnancy, and I'll show you some data with regard to that. But you see rates here. Now, it looked pretty good in the last iteration of the National Survey on Drug Use and Health, because you could see that rates were actually lower here. But then our friend COVID hit, and the story that emerged is something different. So we're seeing actually an uptick in rates of both alcohol and substance use. Now, one thing about the National Survey on Drug Use and Health, it's a very, very valuable database, but it's cross-sectional, and there are no biological verification to the reports that people provide. And so I think this particular data set, this paper and the data that it comes from are really valuable, even though they're regional, because actually, no, that's not the truth. That's the next set. This is just to show you, this is a different data set. This is the Behavioral Risk Factor Surveillance System. And this really is just focusing on alcohol and what you see in pregnancy and non-pregnant and heavy alcohol use. So this is binge drinking, and this is heavy alcohol use. This is a little closer. This is less closer, but bear in mind, alcohol is a teratogen, and heavy alcohol use and binging are really the risk factors that are associated with adverse outcomes, such as fetal alcohol syndrome and fetal alcohol effects. Okay, so this is the data set I was talking about that is regional, but I think it's very, very valuable because they actually had biological verification of substance use. And this was published a few years ago in 2022. And what they did is they used a historical cohort and then a contemporary cohort of 2020. And they looked at the likelihood of having substances in the cord after delivery. And you see here's any substance, and you can see this increment. And then here's opioids, THC, alcohol, amphetamine, and cocaine. Now, this does not, as I mentioned, this is a regional study, and the reasons for this increment could be several. It's not, so it could be that people who like to use substances in pregnancy are moving into Utah. It could be people, and that's generating a higher rate. So it's not necessarily reflective of the world writ large, because there could be some regional effects to this, or it could be that there is an actual increase in prevalence, and this is just reflecting that. So one has to be careful about their inferences of it. Now, there are very important intersectional effects to substance use in pregnancy, and that's reflected in this slide. And this is from the National Inpatient Sample. And what this reflects is ethnicity here. So we have Asian or Pacific Island, Hispanic, white, Native American, other, Black. And here is the extreme likelihood of dying in this bar. And here you have the numbers. The light blue are individuals with a substance use disorder, and the dark blue are people without a substance use disorder. And so you can see these differences, these intersectional differences, especially in Asian or Pacific Islanders. They have a high rate of mortality if they are using substances. So what do we know about some of the risk factors associated with substance use in both pregnant individuals as well as individuals who are at that reproductive age? And for this, I'm largely going to I'm going to use some of the literature, but discuss some of our findings. So, you know, sometimes we talk about substance use in women or substance use in pregnancy or substance use, whatever. There are really important demographic factors that map onto some of these risks. So, for example, the population who are smoking or using cannabis is somewhat different from those that are using opioids or have an opioid use disorder. So one of the big differences is this ethnicity that I mentioned before. And for binge drinking, smoking, cannabis, it is more prevalent in minorities compared to whites. But when you go to opioid use disorder, it's higher among whites. Low income is sort of an equal factor among folks. We don't have as much data about parity, but it may be the same. And we see that unmarried is more common for binge drinking, smoking, but maybe not for opioids. We don't know. And then unplanned pregnancy, we don't know a lot. For demographic factors, binge drinking is more common in older gravidas, whereas as is opioids, smoking and cannabis tend toward a younger age group. So a few years ago, we were asked to submit an application to the CDC because one of my collaborators and I had published questionnaires, instruments to screen for substance use in pregnancy, and there really were not many screeners, and the field really needed some evidence-based screeners that would be readily available and could be used to help identify people who needed to be referred to services. So we did a study, and our aims were to determine the rates of substance use in a diverse cohort. And the context for this is, unfortunately, in many centers at that time, and still probably so, practitioners will decide that somebody is at risk and they'll screen them, but they don't necessarily screen other people because, you know, maybe somebody looks like they are a well-to-do, typically white woman who, you know, would never drink or use substances. And those assumptions we know can be quite inaccurate. So the notion was to develop policies to universally screen instead of targeting a particular population. And indeed, there was a very important study that was in the New England Journal that looked at the rate of detection and referral to DCF, and individuals of color who were pregnant were more likely to be referred to those who were not. So it's important to keep that in mind and keep an open mind about the individuals who may actually benefit from some identification and screening and referral to treatment. So we did this study to compare the performance of various screeners. And then phase 2 of that was to use some statistical methods to develop what might be an even better screener. And we used recursive partitioning analysis, which is sort of an AE method, if you will, to develop a new screener and to evaluate its performance. There we go. So this is some of the background that I mentioned, but it's a little tricky, right? Because substance use is stigmatized, and in pregnancy, it is really stigmatized. So asking people to self-identify is very, very dicey. And we've actually published papers on this and what an impediment, for example, some of the reporting requirements are to individuals seeking prenatal care if they have a substance use disorder. So we wanted to take that into account, and we wanted several measures, and we wanted to see if they varied in their ability to detect those who needed assistance versus those who did not. And we mounted the study, and we used kind of an unusual design. So we identified 5 screening questionnaires, several of them, including the SERPI, which is the one that I had previously developed, and the WIDES, were specifically developed for pregnant individuals, as was the 5 Ps, the original 5 Ps. The NIDA Quick Screen was not, but we wanted to use that to see how that stood up to the others. And then the CRAFT was developed for adolescents who drank and has been applied to pregnant individuals. So the design of the study entailed us, in a counterbalanced way, administering these questionnaires. But before we even did that, we obtained consent and, of course, confidentiality, but not necessarily anonymity. So we told people that we were collecting this information and it would be confidential, unless, of course, there was a problem with them being unsafe or their offspring being unsafe. And as per most studies, one of the risks was a breach of confidentiality. I should mention this study was being conducted in 3 centers. At that time, I was at Yale School of Medicine. So Yale had 2 sites, our public clinic and our private clinic. My colleague, Steve Andersma, who developed the WIDES, was at Wayne State, which is the W in here. And then the third was Grace Chang, who is at MGH Harvard. So we consented people, and then we went to stage 1 of the study, administered the questionnaires as well as demographic information, and we asked them their comfort answering the questions. Then we did part 2, which was met with them, tore up their consent form, saying this is absolutely anonymous. There's no way to trace your information. We obtained a urine sample and we gave them part 2 of the study. Actually, I think we did the urine sample after part 1. And what this enabled us to do is to sort of approximate what it would have been like to be in a practice and be told, we have to get this information, but of course your medical record is confidential, which is very different than anonymous, right? And then obtain a urine for verification. Now, Harvard would not let Dr. Chang do part 2 because they felt that we were not being truthful about this, even though we were not being truthful in a positive way, not a negative way. So she had to inform people at the outset that this was totally anonymous. And we debriefed people at the end of the study to tell them that this was entirely anonymous. Here are some of the screeners. The 5 Ps is actually a pretty common one. There's a 4 Ps plus, which is copyrighted, but the 4 Ps is the original one. Then there's the 5P iteration, and then the 4P plus is the one that is copyrighted. Did your parents have a problem with alcohol or drug use? Do any of your friends have problems with alcohol or drug use? Does your partner, you can get the P part of this, right? Before you were pregnant, did you have a problem with drug or alcohol use? In the month before you knew you were pregnant, did you drink any beer, wine, liquor, or use other drugs? So these questions are trying to be inferential and see if they're not willing to admit to using substances now, what about before they got pregnant, and does that inform their risk? This was the SERPI. Have you ever smoked marijuana in the month before you were pregnant? How many beers, how much wine, or how much liquor did you use? And anything greater than 1 was positive. Have you ever felt that you needed to cut down on your drug or alcohol use? And this item number 2 can be scored in to make to increase specificity and decrease sensitivity. So if someone is low risk, 0, 1 moderate risk, and then 2 to 3 is, whoops, I went forward too quickly. 2 to 3 is high risk. The CRAFT, which is the one that was originally devised to use in adolescence. Have you ever ridden in a car with someone who was high or had been using alcohol or drugs? Do you ever use alcohol or drugs to relax? Do you ever use alcohol or drugs while you were by yourself? Do you ever forget things you did while you were using alcohol and drugs? Do your family or friends tell you should cut down? And have you gotten into trouble using alcohol or drugs? And here's the acronym for it. And the WIDUS, which was developed in Detroit at Henry Ford, in a largely African-American population that that had a high rate of marijuana smoking. So I'm currently married. In the last year, I've been bothered by pain in my teeth or mouth. I've smoked at least 100 cigarettes. Most of my friends smoke cigarettes. There have been times in my life for at least 2 weeks straight where I felt like everything was an effort. I get mad easily. Now, smoking cigarettes is a really powerful question to ask because comorbidity is very common in substance use disorders, and in pregnancy, it's no different. So many individuals who use something that's illicit, or, marijuana, which is quasi-illicit these days, also smoke cigarettes. So that can be an indicator, but it can be sensitive, but it's not necessarily specific. So, and then of course the 4 NIDA questions: 4 more drinks per day, tobacco products, prescription drugs for non-medical reasons, and then illegal drugs. And we did this in pregnancy and before. We also asked the questions before pregnancy. So here are the characteristics of our cohort. And it's pretty much what you would expect to see. This is an inner city Detroit population. Yale had an inner city New Haven population, a public insured population, as well as a private insured, and MGH had mostly a private insured. You can see 12%, 70%, 47%. And by intention, we were trying to get about a third in each trimester. And that largely relates to something that I mentioned before, and I'll talk about later, which is the risk of using substances is different in the first trimester versus the second trimester, third trimester. So it's higher in the first and lower in the third. And then here are the substances that were used. So kind of surprising, any substance, even in a population that was fairly well-to-do, was 18 and well-educated, 18.6, inner city 48.1, and middling 31.6. So I was surprised by these numbers. So, and then we did a screener comparison, and we compared the measures of merit. So what am I talking about here? So depending on what you want your screener to do for you, you may choose a particular metric. So if you want to make sure you don't miss any cases, like you don't want to miss any cases of breast cancer or uterine cancer or whatever, you want something that is highly sensitive because you don't want to miss any cases. If you want to have a high rate of detection, but it could be a problem if you say that this is a false positive, because people get all worried and, whatever. In substance use world, what it means is it could generate a report, right? And, people are worried that maybe their child could be taken away or whatever. So specificity, so being accurate about having a low rate of a non-diagnosis is, you want to have a specific effect, and then accuracy puts the two together. And I don't know, is there a way to blow this up? Yeah. So here you see, this is what the NIDA quick screen was performed quite well. This was pre-pregnancy, which was a little bit worse than pregnancy. So 80%, 74%. The widest, 73% Kraft, SERPI, the high version, the 5Ps, and the SERPI moderate. Now, I mentioned that tobacco in and of itself is a marker of risk. So we took tobacco out of the equation and ran it in that way. And in that way, NIDA was still performing best, and then the widest, and pretty much everybody else. We took our results and we conducted some analyses with a classification tree. So just to talk you through this, the classification tree takes a large cohort. It asks it's just a dumb system, right? Splits the cohort according to a question. And then it splits the cohort again according to a question, and splits the cohort again in terms of a question. So our cohort was 1,220 individuals. Let me see if I can see it over here, sorry. In the past month, how often have you used tobacco products? So, hold it. The first was positive for substance, negative for substance. So and then we were predicting that never use tobacco products once or twice. So you again see this. So we split this, and it, really, it was what we refer to as a terminal node. So this got split. This was a terminal node because it was so highly predictive of a substance. And then the next question for this group, because it wasn't in this group if you said no, you weren't smoking, it was not particularly informative. In the past month, how often have you used illegal drugs? And that enriched the cohort a little bit more, another 27 individuals, and that netted, again, almost 90% in this. So that was a terminal node, and that's where we stopped, because those were really the pivotal questions that got us the answers we need to. So that became our CART screener here, and actually had the best performance, as you can see from Akake's, particularly with regard to specificity, a little less so on sensitivity, but the specificity was so much better that its performance was preferred. So overall, what this project showed us that the screeners varied depending on the particular measure of merit. The NIDA quick screen and a 2-item questionnaire about the use of tobacco and illicit substances had the best overall performance. And then screening for substances can be conducted very efficiently with very few adverse consequences. What about the course of illness? Well, this slide reflects some old data from the National Survey on Drug Use and Health. And it's really a nice illustration of what happens in pregnancy. Now, remember earlier in this presentation, I mentioned that pregnancy is one of the most effective treatments for substance use. And that's what's reflected here. So the first trimester, you see here is illicit drugs, and here we have alcohol, and these are abstinence rates. So relatively lower abstinence rates. Abstinence gets better in the second trimester, and then in the third trimester, at least for illicit substances, it looks great. Sadly, things go south literally in the post-pregnancy interval. So after delivery, people actually start using again. So using substances again. So we refer to this as sort of a pause, if you will. But I firmly believe that this is really a biological clue that may actually help us in the future figure out some treatments for these disorders. And anyway, hopefully more to come on that in the future. So, what do we know about hazardous substance use in pregnancy? As I mentioned, 80% of postpartum individuals relapse to drug and alcohol use after delivery, which is a problem. So, how can we capitalize on the relative well-being in pregnancy? So we decided to see if evidence-based therapy could help us with that. So we combined motivational enhancement therapy with cognitive behavioral therapy and decided to administer this in the clinic while people were pregnant to see if it helped them, A, not use substances, and B, stay substance-free after delivery. We followed participants for 24 months, and this was done quite a few years ago, when MI was much more novel. These were our inclusion criteria: pregnant individuals less than 28 weeks, age 16 or older, positive 4Ps or tweak, and they were randomized to brief advice, which was given by their obstetrical provider, versus the MET CBT, which was 6 sessions. And then we did assessments at intake 28 weeks and delivery and 3 months after. We collected the timeline follow back and urine tox screens. This was our cohort. Their average age is kind of what I mentioned way at the beginning, 25, 24, 25. Average gestation was also about 24, 25. At the first visit, about a third of the population were of Hispanic ethnicity, half were African American. The most common primary drug was marijuana, with alcohol second to that. And here you see Kaplan-Meier curves. So these data are unique because we actually were able to follow them over the course of pregnancy and track when they became abstinent. The National Survey on Drug Use and Health data I showed you before were cross-sectional. They weren't longitudinal. So here you see not just the longitudinal data of individuals, it was a little bit less than 200 over the course of pregnancy, but also by their primary substance. So cigarettes, cocaine, marijuana, and alcohol. And here you have it. Alcohol is here, and this is cocaine. This is marijuana, and here are cigarettes. And these are the probability of abstinence. So the higher this curve and the sharper the curve, the better off that means they attained abstinence much more quickly. So unfortunately, cigarettes was the most difficult in this. And so attaining abstinence from cigarettes was one of the most difficult, whereas alcohol and cocaine were not. I have to think that, the campaign for alcohol must have been effective, although people are warned not to smoke in pregnancy, and it seems to have a less effect. It may be that this is some kind of metric on the relative addictiveness of the various types of substances. That's kind of my inference, but it may not be. There may be other factors at play. Sorry, I'm like, there we go. Okay, and the longitudinal nature of these data allowed us not just to look at abstinence, but also to look at relapse, because you heard about 80% of people will relapse. And again, the sharper the curve, the quicker rate of relapse. So this is the probability of relapse. And interestingly enough, even at attaining abstinence, cigarettes was one of the highest risks for relapse. The condition, or the substance that people had a lower rate of relapse to, was cocaine, which I found to be surprising. Now, there were a lot fewer individuals who had a cocaine use disorder or were using cocaine in pregnancy. So this needs to be interpreted cautiously, but I thought that it was quite interesting. So in summary, this particular study showed that the rate of abstinence was lowest for pregnant individuals who smoke nicotine cigarettes, The rate of absence was highest for pregnant individuals who drink, and the rate of relapse was lowest for postpartum individuals who use cocaine. The rate of relapse is highest for postpartum individuals who smoke nicotine cigarettes. So that's what happens with pregnant and postpartum individuals. What can we do about it? So I want to show you just some of the studies that we did with pregnant individuals to try and help them seek treatment and stop using substances. You may have heard of SBIRT, screening, brief intervention, and referral to treatment. This is something that's typically conducted in general medical settings. We now have recovery coaches that do that in a number of settings, including where I used to be at Yale and where I currently am at UMass. The nice thing about SBIRT is it really, because it is brief and fairly easy to teach, you don't have to be a psychiatrist or a psychologist or a behavioral health therapist to learn it. You can reach a larger number of people, and it can be coupled with the universal screening that I was talking about before. And because it's brief, it's a few minutes, it's more likely to be accepted by both clinicians as well as patients. It really was developed for tobacco use and unhealthy alcohol use, although it's been used for a number of conditions at this point. Motivational interviewing is the heart of the SBIRT, so that is the behavioral intervention, if you will. And the components of MI are understanding the primary substance. So many people will use a couple of different substances. So you ask people to focus on their primary substance, discuss the reasons for using and not cutting down, ask key questions, provide personalized feedback, ask key questions, handle resistance skillfully, and the critical part of this is draw out the change talk. I like to think of this as, in psychotherapy, we're sort of, at least I was taught, when the patient comes up with the idea or whatever, that's when it'll really stick, right? And you have to sit and wait until the patient comes, the light bulb comes on. But here, this is really 5 to 10 minute kind of drawing out that change talk that hopefully will stick. Develop a change plan, summarize and support what the patient's elected to do. So we conducted this study administering an SBIRT by computer and by clinician and to a control condition. So the study was really powered to compare SBIRT by either of these to a control condition, which is clinician administered brief advice. Although, of course, we compared the computer and the clinician. So our outcomes were days per month of primary substance use and post-SBIRT substance use treatments and self-help utilization. Secondary were days of use, cost effectiveness, and abstinence rates. This was our design. So we screened, consented, we randomized usual care, the electronic SBIRT, and then the clinician SBIRT, and then they were followed up at 1 month, 3 months, and 6 months. Our participants had to be at least 18 years old. They had to score at least a 4 on a measure, NIDA measure, the NIDA assist. We increased the alcohol cutoff because it's a little wonky with alcohol in pregnancy, especially, but because if you go to a wedding and if you have a drink, then you could score, and that's not what we're looking for. We're looking for a different population. They had to have used the primary substance at least once prior to randomization. Now, this study was actually conducted in a reproductive health center, so not everyone was pregnant, but it was an at-risk population as well as a pregnant population. This is just an example of the branching that our intervention, we had an avatar, he's called PD, he flies around, and he encourages people to choose one of these buttons. I need to make a change. I don't want to change. I recently quit. I'm not sure what I want to do. And this is my plan. I'm curious, what are the 3 biggest reasons that you decided to make a change? This is all part of based on MI, but not MI. And then there's normed feedback. So this is where you are in terms of how my marijuana use compares, and this is everybody. So the cohort had about just under 400 people, is it right? No, 500 people, about 450. Largely African America, but also substantial in terms of Hispanic and Caucasian. About a third to a half were married, and just under 20% were pregnant. And here we are showing the mean days of substance use stratified by pregnancy status. So this is usual care, not pregnant, and the blue is usual care, pregnant. Here is E-SBIRT, not pregnant. And here is SBIRT, not pregnant. And here are the pregnant cohorts. So the SBIRTs, you can see, are pretty similar. But the usual care was quite different. And that was statistically significant. So abstinence rates were higher in pregnant than non-pregnant individuals, which was anticipated since this is what we see in all of our studies. Usual care was associated with worse outcomes in pregnant and non-pregnant individuals, and SBIRT delivered by computer or clinician were roughly equivalent, although the computer was non-significantly better. And in terms of cost effectiveness, the computer was better. So it was more cost effective. Now, this is just a riff on slides that I've showed you before, which is the rate of using substances, rate of abstinence. This is the flip side of it. So here you see cigarettes. This is from a different study. This is from my Yale Pink and Blue study, which focused on depression and antidepressant treatment. But we had people in it who were using substances. This is marijuana. So the rate in the early part of pregnancy was higher, and then it goes down. People deliver, it goes up. Similar story for alcohol and cigarettes. So this is very interesting. And one of the reasons people say that they stop using substances in pregnancy is they want their baby to be healthy. Well, if you talk to perinatal individuals who use substances, they want to quit, and they want to stay quit because they want to stay quit for their baby, for their life, whatever. But after delivery, it's almost like there is some, protective effect that's lifted. So what might that be? Well, when you look at the prenatal data, it can be it's interesting. So gonadal hormones have an effect on self-administration of drugs in animal models. So the bottom line is beta estradiol promotes cocaine use, and also in various paradigms that are used in substance use research and preclinical data. It increases ambulation, rearing activity, condition place preferences, and seizures. Progesterone, on the other hand, has the opposite effect, and it can reverse the effects of beta estradiol. And progesterone is a neurosteroid. It's synthesized in the CNS. It's neuroprotective. It has increased levels during pregnancy, which are protective of the fetus. It may be useful in CNS injuries like stroke or TBI, although I'll tell you the major studies have not found it to be the case. Its metabolites like allopregnanolone and pregnanolone interact with GABA, glutamate, sigma, and nicotinic receptors. And you may know that there is a new treatment for perinatal depression, which is basically allopregnanolone. So we conducted a study to determine if perinatal individuals with a recent history or current cocaine use disorder would benefit from progesterone as compared to a placebo. And we used oral micronized progesterone for this particular project. This was a 12-week randomized study, 3 months post-treatment follow-up, and we used 100 milligrams twice daily of oral micronized progesterone or similar appearing placebo. And we obtained weekly qualitative and quantitative urine tests as well. And we offered CBT for substance use, although no one really wanted it. We measured benzylcotinine. We obtained the substance use calendar, which is the timeline follow back, cocaine craving, EPDS, which is the Edinburgh Postnatal Depression Scale, and the Fagerson test for nicotine dependence. This was a pilot study funded by NIDA, and so we had about 25 people in each arm. Median age was a little older than our other studies. The characteristics, about half white, half black, and a few individuals who were combined ethnicity. Most were not married. It was a pretty severe cohort. So these are the model data for cocaine use by group. The red is the progesterone group, and the placebo group is in blue. And here you see, this is week 1, 2, and you see what should be happening is happening, right? Over the course of pregnancy, or actually this is postnatal, I'm sorry. So this is the number of days of cocaine use per week. And this is after delivery. So you actually see a decrease in the rate of cocaine use, whereas in the placebo group, it just increased, as you would anticipate. And when we looked at relapse after delivery, it was really powerful. This was a hazard rate. These are Kaplan-Meier curves. This is a hazard rate, and it was almost 5 for the active treatment group versus the placebo group. So that was really using what we see in the real world in observations such as epidemiological observations, longitudinal studies, to try and see if we can figure out ways to intervene that may be helpful for individuals. It suggests that there's some biological plausibility for the effect of progesterone on cocaine use. And that may have been what we were seeing in the earlier study that I mentioned. But unfortunately, these data are limited by the sample size, and a larger trial is needed. We put in for a larger trial, and we got a near perfect score, but then the opioid epidemic hit, and they weren't funding, NIDA wasn't funding anything other than opioid studies. Oh, well. So some of the takeaways: pregnant individuals are not immune to substance use disorders, although it does improve over the course of their pregnancy. The most common used substance is nicotine cigarettes. They also may be the most difficult to stop. Substance use decreases in pregnancy, but after delivery, the relapse rates are high. Screening can be conducted in pregnancy, and SBIRT reduces the use of substances, whether it's by computer or by individual. Replacement of high levels of pregnancy hormones may reduce relapse for some substances. In this instance, it was cocaine. But it may, I know that there's another study looking at its use in methamphetamine. So, and with that, I will go ahead and stop. I'm going to stop sharing, if that's okay.
Great. So that gives us, looks like we have about 5 minutes for questions. So if anyone online has anything, looks like we have nothing submitted yet. So I'm going to give people a minute here or two to submit their questions. Had a couple notes here that I could ask you about while we give people that opportunity. Well, first I wanted to say I liked Petey the Avatar when I saw that.
Yeah, if I were better at slides, I would be able to animate Petey flying around, because that's what he does in the.
Well, I was picturing him flying around. I want that on more of my surveys, so
Yeah.
so that was good. But my question, though, so I know you closed out your slides already, but I made a note about how on slide number 24, which was about, let me look through it because I have the slides open too. What do we got here? Okay, yeah.
Can you see my slides?
I can now. Yeah, they're back up again. So on slide 24, so you mentioned that the results that we're looking at on that slide were a big surprise to you.
Mm-hmm.
And I was just wondering if you could talk more about that. If you could talk about why it was a surprise
Oh, sure.
and also what you were expecting to see.
So this is just all comers in a clinic, in a pregnancy clinic. And this is quite rigorous because these were biologically verified substance use. And to see these rates, or they're biologically verified or self-report, I want to say, if somebody said that they were using a particular substance, even if their urine was negative, they got scored positive. If they said that they were not using a substance and they scored positive, they were scored positive, and their urine was positive, they scored positive. But I just thought these rates for any substance, over 18%, nearly half, about a third, were just a lot higher than what I would have anticipated when you look at some of the data that I showed you from the National Survey on Drug Use and Health.
Oh, yeah.
So that was what was surprising to me. And, what we did is we were quite intentional about first, second, and third trimester. So, and these were cross-sectional data. So I can't tell you one person in the, first trimester who scored high, what happened in the second trimester. But I thought that I thought it was surprising that we had such high rates. And it kind of debunks the notion when you look at the MGH clinic, which was a well-to-do, commercially insured, largely employed Boston population, that the rates were almost 19%.
Okay, thank you. So now we do have a couple questions from our audience, and the first is, well, first of all, thank you for the great presentation, they say. So given that the computer delivered some of the brief intervention performed as well as the clinician delivered intervention, so has the computer approach been scaled up at all?
Good question, and it has been scaled up. I know right now they're wrapping up a study in Michigan where they're using a computerized intervention like that for smoking cessation in pregnancy. So it has been scaled up. I'll tell you, one of the things about this program, and I have limited number of slides on it, is the pictures can be very powerful. So let me just give you an example. If you say you're smoking, and one of the feedback loops for the smoking is we have a little video of how much money you could save if you weren't paying for packages of cigarettes. And you just see the coins drop and you see this pile. And then the screen goes to the kinds of things that you could buy, flat screen TV, a trip to wherever. Those are very, very powerful messages. It's like a picture is 1,000 words. So I think that really enhances the intervention to a great extent. So I know that they're using that for smoking cessation in Michigan, and we hope to be able to use it in other settings. I can tell you we tried to scale it up at UMass on the inpatient setting for individuals who had cardiovascular disease and smoked, and it's kind of been a fail, not because it doesn't work, but because the patient population inside a hospital is so sick that they don't have phones, they don't want to look at phones, they need a lot of help. There's some age complications, people not so used to using computerized intervention. So I think there are going to be some limits, but.
Yeah. All right, well, thank you. That brings us to 1 o'clock. So Dr. Yonkers, I appreciate you being here today on behalf of UW. Thank you. And everyone online watching, thank you all. And I hope you can join us again next Friday.
Thank you. Nice to see you, Jürgen.